Attending 12 to 101.
Dr. Angelini?
This is him.
Hey there. We also have a case to present as well.
Wonderful.
So we can go after you.
Whenever you want to start, you tell me. Is anybody else reserved to come?
No, we've got 6 of us here.
Okay.
So
Five cardiologists.
On our end, we've got our group, and I'm not aware of anybody else.
I think people at UCLA are going to be a little late, but we'll find out.
Okay. Dr. Tobis has cases, he says, so.
He said that he cannot come, or just it was difficult?
He wrote an email and said he would try.
He said he would try, but you know what that means.
He usually makes miracles.
Yeah. All right.
Okay, do you want to start? Am I on?
Yeah, let's get going.
All right. Is Eric coming today?
He's here with us, but he's in and out. He's backed up in clinic.
Very good. All right, then we are going to have 1 or 2, depending on how much you have to present, cases that we could enjoy discussing. The first is one of subject of hypertrophic obstructive cardiomyopathy, and is dealing with the issue of is the gradient the full story of this disease, and what mediates both the symptoms and the evolution, or there is something more after we eliminate the gradient. Let's see this interesting case. So as we know, hypertrophic obstructive cardiomyopathy is a form of cardiomyopathy in which a gradient becomes apparent in the history of a genetically predisposed patient. And chest pain is the main symptom, but not the only one, usually accompanying dyspnea, dizziness, or syncope, or sudden death. In the recent past, it has become clear to all people involved in the treatment of this rare but definitely substantial population in the cardiology clinic that the gradient is a very attractive parameter to follow in the evolution of a patient, both because it marks the onset of the symptoms when it appears in the life of a patient born with this disease, and because it is a definite and localized part of the disease that can be treated effectively before with surgery, now also with arcoseptal ablation. We have a large experience in this center, like in many other, especially in Europe, but also in the States, suggesting that if we eliminate the gradient, first we eliminate the symptoms, especially chest pain typically disappears during the same procedure at the infusion of alcohol, but also that if you eliminate the gradient, the progressiveness of this condition is usually stopped. Let's see if we can deal with this patient. A 28-year-old female, active and successful administrator in a large corporation, never previously considered to be limited by chronic pain, but eventually became a victim of chronic pain, and this is the story. She was admitted to our center after having initially a severe pain and progressive shortness of breath 1 year before the admission to our hospital. In the neighboring hospital, She had both a catheterization, echocardiography, and eventually surgical myomectomy of the subaortic septum that was very successful in eliminating the murmur, the gradient, and initially also the symptoms. But for the last 12 months, she had been even admitted 3 times in an emergency room because of intolerable chest pain, requiring more recently even opioids. She was also again on beta blockers, hoping that this was something reachable or controllable with beta blocking agents, but a murmur never occurred, and she was studied by echocardiography before coming to our center, showing that there was no subaortic stenosis. When she comes to our clinic, she has a history and appearance of a patient chronically ill and constantly in pain. There is no evidence of acute MI, but the pain is prolonged. They require intravenous narcotics, and the patient is totally bedridden and quite sick. The pain is as typical as she had it before. It's a chest pain, most frequently substernal, not radiated, but described from time to time with different locations, which is suspicious to me, but this is what the description is. It's a pain that requires so much drugs that she's unable to walk. It's not really physical incapacity, but the fact that she's under the effect of opioids. It's accompanied by shortness of breath and palpitations, but basically the palpitations are related to regular sinus tachycardia, even taking 300 milligrams of metoprolol a day. Let's see what the test showed. The EKG was altered by this recent surgery because of left bundle branch block, which is a frequent complication of surgery. But the PR was normal. There were no severe ventricular ectopic beats or ventricular tachycardia. The enzymes were negative for acute events. Had myocardiomyopathy or chest X-rays and no signs of congestive heart failure. She had a positive nuclear stress test with a PET scan for anteroseptal and anterolateral reversible ischemia. That's unexpected, but not totally unseen even after a successful myomectomy. This is more than the area of the upper septum, but it's in the area of the proximal LAD. An echocardiogram showed a moderate asymmetric septal hypertrophy from 1.8 at the level of the upper septum where myomectomy was done, and 2.8 lower down in the mid-septum, 1.3 in the free wall. There was no SAM, no systolic anterior motion of the mitral valve, and trivial mitral insufficiency. There was no subaortic gradient by echo at rest, nor with Valsalva maneuver, and the left atrial size was normal at 3.5 centimeter diameter. So she had a heart catheterization. They showed that there was no gradient below the valve, both at rest and with the dobutamine stimulation, that resulted in worsening of the chest pain symptom to intolerable and requiring narcotics. In angiography, they were going to see in a few seconds, there was evidence of systolic blanching of all the septal branches that these appear completely in system, both at baseline and even worse with nitroglycerin administration. There's a mild mid-LAD systolic myocardial bridge effect with systolic narrowing of about 50%. This is worse with nitroglycerin intracoronary infusion. The ejection fraction is 55%, almost normal, at the bottom of the normal spectrum. When we're going to see the angiogram, you will see that the first septal branch, we're going to change? Okay. Okay, this is an angiogram at baseline. She's tachycardic. As you can see, I want to indicate what I'm commenting on from time to time with the arrow. You see the first septal is the one
that's crazy.
in this position, and the distal part is very narrow, diffusely narrow, but suddenly narrow. And in systole, the artery disappears completely. The same occurs for all these branches. So there are several, if not all of the branches of the LAD to the septum that totally occlude in systole. The rest of the tree is normal. There is a mild muscular bridge, myocardial bridge effect at this level.
Oh yeah, a little bridge. You see it?
Yeah.
Any questions?
Let's see where he's asking us.
No questions so far.
So at this point, we decided to do also an acetylcholine test to see if spasm was involved and if or not it was able to reproduce the symptoms. And indeed, acetylcholine produced symptoms, caused diffuse narrowing, but of mild degrees, and a more extensive systolic blanching of the coronary arteries. You will see during this injection that there is an unusual phenomenon. When the injection is done, you will see here, you see this wire is positioned in the LAD first septal, and during the injection, evidently the proximal valve was not very tight, and the pressure of the injection advanced the wire where the wire wanted to go spontaneously, and it went to the ascending aorta. Do you understand what is the implication of this behavior? From the septal to the ascending aorta, what's the mechanism? Anybody ventures with an answer from there?
Is it like a coronary cameral fistula that?
This looks like that.
Yeah, this is not an unusual event after septal myomectomy. It is evidence that some septals were cut off and left bleeding into the left ventricle. This is curious, is unusual that you can see because the amount of blood is not very large and it goes into a large cavity and immediately contrast is diluted. But it could be part of the generation of chest pain because it's a steal phenomenon. The blood doesn't go to the myocardium, that goes from the first septum to the upper septum, but into the left ventricle. So it could be a second reason for chest pains. As you see, the coronary arteries have this evidence of diffuse small vessel disease, we will call it. At this point, the wire goes into the direction of the septal that goes to the presumable AV node. We're trying to see if we could avoid the only serious complications from a new septal, a new intervention of septal ablation with alcohol that in the presence of the left bundle branch block is frequently complicated by complete heart block and the necessity of a pacemaker. So we're trying to see if we could occlude the anterior ramification of the first septum and maybe put a 1.5 balloon to occlude the advancement of alcohol in that direction. As you see now, the balloon inflated in the proximal LAD. One wire is in the AV node directed branch and the other one in the main. As you see, the wire itself is occlusive of that anterior bifurcation, so you didn't require to go to the balloon to occlude it to eliminate most of the flow in that direction. So what we did is after long discussions if it was or not an important problem and an important or hopeful solution, we discussed either to continue a medical treatment that for a year didn't show any success, or to consider ablation of the mid-septum below the upper septum that was effectively eliminated, and with that this gradient had disappeared, or obviously changing the medical treatment to include disoparamide or verapamil, beta blockers, especially to eliminate or decrease the amount of spasm that could be involved. There was a question also if it was necessary or not to have, besides the pacemaker, especially in case of using ablation, in ICD, because we would lose further myocardium. So the final conclusion was to try to see if we could prove the hypothesis that chest pain is actually originating in the mid-septum, that is still hypertrophic, has some problem of both the spasticity and leaking blood from the septals that were cut but not occluded, and creating steel, besides systolic compression because of myocardial bridge effect in the septum from myocardial disarray. The hypothesis is based more than in a large experience on the fact that is frequent in the context of arcoseptal ablation with severe symptoms, especially chest pain at rest. It's frequent to see a total disappearance of the chest pain in the cath lab. As the patient wakes up, it says, "Oh, doctor, I don't have any more of that chest pain. I feel I can now breathe normally and there is no more pressure." So it is possible that even the absence of subaortic stenosis or gradient in the subaortic region, that we can affect one of the mechanisms of chest pain, which is myocardial disarray, that likely goes with the intramural pressure above the systemic levels of pressure, and alcohol could eliminate that pain. The problem was bad enough as to consider heart transplant for this type of pains. So definitely it was worth it to consider an out of the routines procedure that had some probability of success. The possibility that with the alcohol ablation of the first septum we could eliminate the LAD myocardial bridge was very low, because this is not a vessel that is nutrient to the myocardial bridge of the LAD. So with the risk of having complete heavy block and the risk of a pacemaker, but with this device of occluding the anterior septal branch that goes to the AV node, it could have been a possible mild intervention. Next. So we inflated the balloon just proximal to the trifurcation of the first septum and infused over 2 minutes 1.5 cc's of pure alcohol that caused no arrhythmias and caused the worsening of the chest pain for a few minutes, and then eventually, after 5 minutes of balloon occlusion, the patient had no more pain and no pacing was required, not even temporary. There was a temporary pacemaker wire with an external pacemaker generator. After the procedure, the patient felt improved. She started getting off narcotics and active on the floor, able to walk on the corridors for a significant time for her. The pacemaker, temporary pacemaker wire was pulled after 2 days, and no arrhythmias were noted in telemetry. The CK peaked at 800, and the QRS did not change in the EKG. The echocardiogram and the MRI will show what was done. The echocardiogram at baseline is this. The upper septum, as you see, is showing the typical indentation after septal ablation, after septal myomectomy. As you see, it's a very short cut, and the distal septum, these are 2 centimeters, is more than 2 centimeters in thickness. There is no subaortic stenosis and no mitral insufficiency. The ventricle is not brilliant, but the free wall moves well. The septum is thick. So this is after the procedure. This is during the infusion of bubbles to see the destination of alcohol if we had injected at this level. Basically, the area of alcoholization is between the area of the previous surgery and the upper mid-septum, where the thickness of the wall of the septum was the highest. This is during the infusion. The tattooing remains. Next. And this is 2 days after an idea of what was left. We want to show you the MRI to show where the scar was left at. You see this amount of septal thickness is pretty amazing. It's about 3 centimeters here, and this is where we injected most of the contrast at the level of the upper head of the papillary muscles. Next. Yeah, this is the study that was done before alcohol ablation, actually. Let's go to the next. Next, I want to see the MRI with the scar. Okay, this is a still before and after infiltration with alcohol. So it's in the right place, and the question was to find out if it made any difference. The initial response was very hopeful. Next slide. This is basically to show in a different section the ventricle before and after in the same section. There's not much decrease in left ventricular function after the localized infiltration and infarction. So the patient could be discharged a few days after the procedure with the hope that this early good result could be maintained. She was given a milder dosage of metoprolol and given an appointment for a 15-30 days follow-up, which time she said that after the initial decrease in chest pain, the chest pain returned. So at 1 month, she was at the level of 50% of the amount of pain off narcotics, but still with uncomfortable pain. And 2 months after, this is what it is now, 2 months after, she has mild to moderate pain, but the pain is still present and disappointing at a certain level. Any comments?
So the alcohol septal ablation really was not treating myocardium that was primarily the problem when she was first diagnosed in terms of symptomatology. This was more treating the myocardium that was felt to be affected by the Steele phenomenon from the fistula, the post-op fistula. Was that the thought process?
The thought process was to treat as much as possible several mechanisms: the fistula, the systolic compression, the intramural hypertension. These patients with myocardial disarray have chest pain from just the disarray, not necessarily with the left ventricular gradient. So there is a possibility of explaining a good result that sometimes occurs, but we didn't know exactly what it was, neither the mechanism that caused the pain nor if it would work by eliminating the upper septum below the area of myomectomy. Definitely is more than the leak of blood, but that too.
Do you feel that the areas of the more mid-septum that are clearly affected by septal perforator compression, would those be amenable to further alcohol septal ablation to take care of those symptoms, or is that something that would be sort of outside the bounds of what we do?
I don't know. We decided at this time to watch her and help her and support her. There is the component of mental attitude and chronic pain dependence on medication that confuses the symptomatology. Thinking of destroying muscle, it's always a question, an open question, up to which point can we continue to destroy muscle when at a certain point there could be too little myocardium to carry on the function of the heart, which is to contract. So we hope that we have made an objective improvement of some mechanism of pain, but the residual pain, I don't know if it is for a chronic pain unit specialist to deal with more aggressive procedures. I don't think neither surgical nor alcohol ablation can be safely considered at this time. It's probably we probably took off something like 20% or left ventricular mass. But she started with left ventricular mass of about 50% more than normal, so it shouldn't be inadequate to carry on with heart failure. But the chest pain is quite persistent, and it's not typical, but it's persistent, disappointing, and limiting. She is disabled. She's not able to go back to work. We hope in the next few months she will have better symptoms, but this is where we are at this time.
Dr. Angelini, did you feel that even though on CAT the LAD bridge was mild, that it might be more hemodynamically significant, or are you pretty confident that that's not causing any symptoms as well?
Myocardial bridges are almost the rule in patients with hypertrophic cardiomyopathy, especially the ones that have obstructive behavior. And the majority of the good results of alcohol ablation or myomectomy are in the absence of any treatment of myocardial bridge. Myocardial bridge in general is benign and not accompanied by chest pain. In her case, the amount of systolic compression is definitely not even suggested that it could be enough limitation in myocardial blood flow as to cause chest pain at rest. But the whole presentation of hypertrophic obstructive cardiomyopathy is still incomplete in our knowledge. It is true that talking about gradient, it's simple and is basically identifying one of the main mechanisms, especially the progressiveness, because more gradient, more hypertrophy, more gradient. So it is important to stop that mechanism, but it is not true that chest pain can only come from the gradient. It's mainly myocardial disarray, most likely, is the myocardiopathy in itself, which is not only evolving with hypertrophy with time, but is congenital and related to genetics that are not changed.
Dr. Angelini, Alberto Morales here. That was a very, how you doing, sir? Very impressive case. I've never seen anything like that. Is that a known, is that a frequent complication of septal myectomy? Did we discuss with the surgeons perhaps and see, do they cauterize the myocardium after they carve a piece of tissue out to avoid this, or how does that happen?
To avoid the
I guess the septal to left ventricular outflow tract fistula type of...
The leak, yeah, the fistula. It is quite frequent. It is quite frequent, but usually clinically irrelevant. We had a similar case with a big leak that could be seen angiographically in another patient 15 days after this one, but that patient didn't have any chest pain. I don't know if the leak was important, but in this patient, that part of the first septal was occluded, so the leak was eliminated. But I don't think the present cause of pain is as much the leak as the disarray and the intramural pressure that is. In these patients, usually if you measure intramural pressure in dogs with IHSS, there are frequent dogs in some species that have congenital IHSS. If you measure the pressure in the intramyocardial area of the septum, you see that the pressure is something like 50 to 80 millimeters of mercury higher than the left ventricular, and higher even when there is a gradient of the left ventricular apical pressure. So it is something that probably the outflow tract gradient doesn't measure, but has important repercussion because it creates an increased demand of the myocardium, with the decreased supply, in this case both the fistula but especially the systolic compression that is so severe in systole, the blanching eliminates all septal flow. But this is quite unusual. This is quite unusual, and the surgeons that saw this patient after surgery were as surprised as we were. And facing a patient so desperate and symptomatic and disabled, we tried to opt for an alternative aggressive attitude, but we are not ready to claim any success yet. There is some improvement, but I don't think we cure everything, and I don't know if there is a component that is mental at this point from drug dependence, or it is related to this disarray that obviously is not completely eliminated. But it's something that will give you a follow-up, and we'll discuss further at the longer term of follow-up.
Awesome.
You want to go to the
Thank
next
you very much,
patient?
Dr. Angelini.
Thank you.
Do you have another presentation for us, or?
No, you can go to yours.
Okay, I have we have a case to discuss with you to get your opinion about this, since you're the leading expert in this area, obviously. And I have a medical student here who's done great work, and her name is Asma Marine, and she'll be talking to you about this case that I saw just recently, and your thoughts about it, and how we should go about managing it. We'll show the images, the pictures, and everything, and kind of get your opinion about it. So here we go.
Very good. Thank you.
Can you ask her?
Can you see the presentation?
Right.
Are you able, did the screen come up on your side?
Yes, we see the title.
Okay.
Anomalous right coronary artery from the left sinus.
Hello. This is Asma. Nice. Right. Okay. Okay. All right. So I'm going to start with this case that we had. Okay. So the case was a patient who's a 20-year-old Caucasian male. He actually presented to our clinic for evaluation of hypertension. On further questioning of his history, he revealed that he recently had a H. pylori infection. During the course of his treatment, he began to experience severe epigastric and retrosternal discomfort. He was actually hospitalized in St. Joseph Hospital in Lutz, Florida. EKG at that time showed a non-specific ST and T wave changes. A D-dimer was done, which was elevated, which was followed up with a CT angio. The results of that was negative. At that time, they changed his medications for the infection, and his symptoms were resolved. So at the clinic, he did admit to experiencing dizziness and palpitations with exertion. He also complained of a retrosternal discomfort with coughing, deep breathing, exercise. He rated it between 3 to 5 out of 10, and it lasting a few minutes. Lastly, he also basically mentioned that he was told in the past by doctors that he had some sort of anatomical variation with his heart, maybe thick muscles, but he was not sure about that.
Can you elaborate a little bit on the chest pain? In coronary anomalies of this kind, you can have chest pain, both typical, related to exercise, maybe responded to nitroglycerin, and atypical, coming at rest and varying in distribution in radiation and in different locations from time to time. You think This was fairly typical or atypical?
It was very atypical. You know, anytime I see a young man in my office, I always think of congenital things and ask triggering questions. He really wasn't there for these symptoms. He was really there for an elevated blood pressure that was found at the time of his hospitalization. And I guess he saw on follow-up his primary care physician, who's a pediatrician, and noticed his blood pressure remained elevated. She had messed around with his antibiotics for his gastritis and esophagitis from his H. pylori infection, whatever was going on with that. And so I asked him how his symptoms were, if those symptoms had resolved, and he said yes, for the most part, those symptoms had resolved. And then I asked him about other questions about activities and this and how active he is. And he expressed to me that he does from time to time, you know, experience some shortness of breath with activity. He was very vague about that. He felt that was probably deconditioning. But then he says, you know, he gets some episodes where he gets a little dizzy at times when he does exercise, but he tends to think that those episodes occur when he's lifting weights more than with running or aerobic activity. And the chest pains were very sharp, atypical. Sometimes they occurred with activity. Sometimes they occur post-activity. Sometimes, you know, described them more as a fleeting chest pain syndrome that was resolving. I really didn't appreciate that these were probably a problem for him, but there was way too many little pluses and pluses in a young guy who's coming to see me, and I take that as a probable positive enough to warrant a screening on this young guy. And so that's kind of how it went about, you know. And his blood pressure at the time he came to see me was, you know, borderline elevated. He drinks alcohol socially, smokes a little bit, drinks some caffeine. So I attributed some of that blood pressure to that rather than other things. But there was some other stuff going on in the background that kind of triggered some bells, per se.
Was he involved in sports?
Not an athletic, but does you know, was running, you know, for activity and exercise, likes to go to the gym and run and lift weights from time to time, but I hadn't done it in over a year and was wanting to get back into it, you know, so he saw me thinking, you know, for the blood pressure problem, and I said, let's hold off on any activity until we do a thorough evaluation on you first, and that's kind of how it went about. But not an athlete, not lifting weight, not for any competitive sports or anything like that.
All right.
Not in the military either.
Very good.
So as Dr. Morales summarized his past medical history, just a hypertension or elevated blood pressure, not really hypertension. He and the recent H. pylori infection, he had no other medical history, no surgical history. He drinks and smokes socially. He doesn't have any family history of any congenital heart disease such as HOCM. Otherwise, his review of systems was negative. His vitals, only his BP was elevated at 130/90. Everything else was within normal limits. His physical exam and as well as his labs were within normal limits. So we did do an EKG, which showed non-specific ST T-wave changes. So you can see some T-wave inversions in B5, B6.
Would you call it left ventricular hypertrophy?
Yes. Yeah, I did. He's a young kid, you know, and so I think he has just enough voltage criteria for sure to meet. He's. I think I counted it back then. It was, you know, in the range, definitely. I mean, he's a young guy, and you know, you're allowed to have a little bit more voltage criteria for a young guy, but definitely borderline with some non-specific ST changes.
The T is important.
Yeah.
All right.
So given his vague presentation of chest pain and his age, Dr. Morales, as he said, he did go on to screen him, and he did a CTA. So from this CTA, you can see that he has an anomalous right coronary artery coming from the left aortic cusp. It does have an intra-arterial course. So this is a sagittal view. Sorry, coronal.
You can touch it, yeah.
Again, you can see it right there. It shows that it goes between the aorta and the pulmonary artery. Here's the
Can you stop it at the level of the ostium? One by one until you see a slit, a very narrow, laterally compressed ostium. A little more, a little more. That's the ostium. Stop. Back one. You see, this is what we call the Ciangangelini sign. This is the compression between aorta and pulmonary artery that this type of course implies in all the patients we have studied. We have the process of publishing some 70 patients with intravascular ultrasound. All of them have the same. You see also that there is an indentation on the pulmonary artery by this intramural. We will see by echocardiogram, by intravascular ultrasound better, but this vessel is inside the wall of the aorta, more in between aorta and pulmonary artery, but it does cause a compression of the wall of the pulmonary artery. This is a very nice study. You see also in the last picture before, the size of the distal vessel of the right coronary artery with respect to the intramural section. It's a significant stenosis. Angiographically, it's probably in the range of something like 60% in area.
And that's pretty much, I think, where we called it. I think we measured it out around 70%, 65 to 70%.
Okay.
And
very good.
Let me show you our IVUS equivalent after I show you a couple more views here. Here's a two-chamber view. And you'll see it coming around here, right there.
Yeah, that's perfect. You see the distal vessel is about 4 millimeters in diameter. So this is a dominant right.
Yeah, very.
Without seeing the end. So it's a vessel that can cause symptoms. The symptoms are atypical, and it's a big discussion. There's the left.
So here we have some 3D reconstructions of the vessel. You can see there's a right coronary coming from the left aortic cusp. And then
narrow and pinched compared to this side.
Yeah.
You see the size of this artery at the beginning is different than the distal. In some projection you see it better than in others. The middle reconstruction image shows that the proximal is compressed in that view. But you need to go in the right anterior oblique to see the compression. In the left anterior oblique, usually not apparent. Actually, the diameter you see in the left anterior oblique is even larger than the distal. Yeah, it's very close to the left ostium, the left coronary ostium.
So here's our IVUS equivalent. I don't know what you feel about this, Dr. Angelini, but this is what we call coronoscopy. And here's a nice representation of looking inside, and you can see the left main ostia here, and you can see here the right coronary with an intramural course in the aorta. With a slit like that's basically showing you looking from here outward. This is that view right there, and right here is the left main. What do you think about that?
I saw these pictures frequently. They presented as evidence of significant stenosis. I think they only show the presence of tangential origin. But you cannot measure severity of stenosis by this method.
Okay.
You need to enter into the artery and maintain some sort of cross-sectional area measurement to be able to measure stenosis. Definitely is intramural, definitely is tangential. There is a slit-like orifice, but you cannot say if it is severely stenotic or less. It is interesting that we had recently here at Texas Children a meeting of expert surgeons specialized in unroofing of the right coronary artery in these cases. And I forced the discussion specifically because nobody uses IVUS. How can you measure the severity of stenosis objectively and make some decision at the end if to operate or not to operate and what the results are if we don't have an intravascular sort of imaging? And basically 0% of the surgery, this is representing a major part, probably 50% of the academic centers in the States. 50% of the surgeries are done at this time on the basis of either CAT scan angiography like this or echocardiography. Can you believe only echocardiography today?
Unbelievable.
The idea of the severity of stenosis. So the majority of the patients have a negative stress test and they have this image of anomalous origin, but we cannot quantify stenosis or ischemia and ischemic burden without knowing much more. You need to know the severity of the symptoms in some sort of a quantitative scale. You need to know objective evidence of ischemia with a stress test that should be either by echo or better by treadmill nuclear stress test. But at the end, you need to have some sort of objective evidence of stenosis. And this cannot come but by IVUS or OCT, optical coherence tomography. Yeah. You did not do an angiogram, the selective coronary angiogram?
He's a young guy. I felt I got, and I was going to talk to you about that before I decided to go that route. If anybody's going to touch this kid, it'll be you. So, but let's go on with what we did do, yeah. And then you tell us what you think. What else? So here you go.
So, so in conclusion, from the CCTA, we saw that he does have a slit-like opening, acute angle takeoff. He also has an intramural course and an inter-arterial course. So we wanted to see if we can document myocardial ischemia or see if this anatomy is affecting the perfusion of his heart muscle. So we did a dobutamine MRI. He was not able to reach his peak heart rate of 170, and he just had some nausea and vomiting from the procedure, so we had to stop that. He did reach a submaximum heart rate of 143. At that heart rate, he didn't have any, his exam was within normal limits. He didn't have any problems with perfusion.
Yeah, and we usually follow that with a perfusion. We don't have it in here, but his perfusion at this submaximal level was normal, and there was no scar at the level of the RCA territory or the RV free wall. I think there's been some cases of looking at RV free wall subendocardial infarctions to assess for possible, prior subendocardial infarctions and stress-related ischemic events, but we didn't see any of that. Here's a two-chamber view here at rest, here at low dose, and you see nice augmentation of all the walls, especially the inferior wall. And then at submaximal, again, pretty normal contractility without wall motion abnormalities. Here's a left ventricular outflow tract view, looking at the inferior lateral region, and we got nice augmentation with no wall motion abnormalities there, no ischemic mitral regurgitation or anything like that.
I was wondering by the EKG that is fairly suggestive of apical cardiomyopathy. and by some cuts of the cross-sectional cuts of the apex, if there is an apical obliteration and an unusually severe hypertrophy at the apex,
Just
there is
looking
no
at
apical aneurysm.
Yeah, we didn't find any. Yeah, the wall motion at the apex and short axis cuts all the way through the apex look pretty normal. I was expecting to find. My first thought was let's do an echocardiogram and just screen the coronaries, but he had enough chest pain and other symptoms. I said let's add a CTA in addition to that. His echocardiogram was essentially normal, and we did strain imaging and all of that, and that was normal. And here on the MRI images, going sweeping through the apex, we didn't find any unusual thickening or hypertrophy, even though his EKG looks a little abnormal.
Yeah. So we are left with a dilemma. Is the pain bad enough as to justify escalation, or we can live in with beta blockers and
so we didn't get to max stress, so we decided, hey, let's, I don't think we've proven anything, although all the studies that I think are out there, I think you and the colleagues recommend submaximal stress test. Well, I didn't know that. We went ahead and did a treadmill exercise echocardiogram, and we did get to peak heart rate. And, hemodynamics and EKG-wise, everything looked fine. There were no wall motion abnormalities at peak stress or nothing. So again, 2 stress tests negative.
Yeah.
So just some information on coronary anomalies. So coronary anomalies have an incidence range between 1 to 1.2 in the general population. The most common is left circumflex from the right aortic sinus. Right anomalous coronary artery from the opposite sinus is found in 0.25% of the cases. Study that by Dr. Angelini, looking at 1,950 patients using coronary angiography, showed incidence of 5.64% with a rate of right coronary anomalies from the opposite sinus of 0.92% and left anomalous from the right aortic sinus of 0.15%. So in majority of the cases, coronary anomalies are benign and asymptomatic. Anomalous coronary arteries from the opposite sinus are one subtype which are associated with sudden cardiac death. Left anomalous from the opposite aortic sinus is less common, but it has a higher rate of sudden cardiac death in comparison to a right anomalous artery. So the right anomalous from the left aortic cusp can be further divided into 4 subtypes that including high intra-arterial course, low intra-arterial course, retro-aortic, and subpulmonic. So the high intra-arterial course, the anomalous artery courses between the aorta and the pulmonary artery. This is associated with adverse cardiac events and symptoms, and there's 2 theories behind this. One being that during exercise you have engorgement of the vessels and you have mechanical compression of the right coronary. Another theory is that you basically, with the repeated compression, you have damage and you have to the artery and you have vasospasms causing ischemia, leading to symptoms and sudden cardiac death. In a low intra-arterial course, you have the anomalous artery coursing between the aorta and the right ventricular outflow tract. So during systole, the right ventricular outflow tract actually contracts, so you don't have the same mechanical compression on the anomalous artery. So subpulmonic is the artery actually courses in the septum below the pulmonary valve. So if you look at the image right here, if you only look at the axial image, you wouldn't be able to distinguish a high intra-arterial course from a subpulmonic, so you kind of need to see a different view, and from this view you can tell that you can distinguish a subpulmonic from a high inter-arterial course, which is important because it impacts the management of the patient. This is benign, and this is can be associated with sudden cardiac death. So the presentation, like I mentioned earlier, is usually asymptomatic, and the first symptom is often sudden cardiac death. In 1/3 of the cases, patients can present with chest pain and syncope 24 hours before sudden cardiac death. So the pathophysiology behind this, there's several theories. It seems like, and there seems to be a combination of anatomical and physiological obstruction leading to ischemia and sudden cardiac death. It could be a single event of transient ischemia leading to malignant arrhythmias and sudden cardiac death, or it could be another theory as that you have several episodes of ischemia that lead to injury and fibrosis, and this leads to a patchy fibrosis predisposing the patient to malignant arrhythmias and sudden cardiac death. So what is called the high-risk anatomy is a slit-like opening, acute angle, intramural segment, and intra-arterial course. So in a slit-like opening, when you have a vertical compression of the aorta, the area is less in comparison to if you have a circular opening. So this predisposes the patient to ischemia. If you have an acute angle of takeoff, you can have kinking of the vessel. An intramural course can lead to ischemia because it's often hypoplastic and stenosed. And we mentioned why inter-arterial course can lead to ischemia earlier. So it seems it's a combination of all of these features that lead to ischemia, not just one. In addition, it was also discussed in literature in a paper by Taylor that if a patient has an age younger than 30, they're at a higher risk of sudden cardiac death. So in a workup, there's two things we're looking at. One, what is the exact anatomy of the artery? So what is the course that it takes? And second is, can we document any myocardial ischemia, because that's going to affect the decisions that we make. So a stress test, it was mentioned in literature, is often difficult to document ischemia using a stress test in these cases. Coronary cath, one of the problems with that is with cannulation if it's an acute angle, but I know there's catheters that would be able to do that. So with cardiac magnetic resonance imaging, it's not so good at determining the anatomy, but it can help with seeing if there's any problems with perfusion. So CCTA is very, very good at determining the anatomy and basically seeing if there's any of the high-risk anatomy, which is very important because it increases the patient's risk of adverse cardiac events. So what are the management options in patients who have these coronary anomalies? So the first one could be observation and medical management with beta blockers and telling the patient to avoid extreme exercise. Another is stenting. One of the downsides to stenting is that there's a high risk of restenosis. It's thought that this could be secondary to the repeated phasic compression. Coronary artery bypass, one of the negatives to that is competitive flow. And with reimplantation and roofing, you make a new, you basically reimplant the right coronary in the left aortic sinus. But one of the negatives to this is that you can damage the aortic valve during the surgery, so there's some risk. So what are the indications of surgery? If you look at the ACC-AHA guidelines for 2008, so you do need to document cardiac ischemia in patients who have a right coronary that comes from the left aortic sinus. There's also class 2A evidence that suggests that revascularization can be beneficial if you document vascular hypoplasia, coronary compression, or any obstruction to flow, which was not the case in our patient. So other opinions on when surgery should be recommended include if there's any disabling symptoms, if there's area of stenosis more severe than 50% on IVUS, if there's a large dependent myocardial territory, or if there's reversible ischemia. So one of the important things is to see if we know what is the risk of sudden cardiac death, and if we can quantify that in patients who have a right coronary anomaly from the left aortic cusp. So one of the largest studies was in the American Armed Forces Institute of Pathology, where they looked at 6.3 million 18-year-olds who underwent intense military training for 8 weeks. There was 64 cardiac deaths, and 33% of these were related to a left anomalous coronary artery from the right cusp, and there were 0 from the right. So this does show that the left has a higher risk of sudden cardiac death, and the right does not. Still, it's not that specific to our patient. Another study reported in literature was on autopsy reports, and it showed that the left was associated with 57% mortality rate, and anomalous right was associated with 25% mortality. But again, as analyzed in Dr. Angelini's 2007 paper, if you were to assume that the incidence was of anomalous coronary arteries from the opposite sinus was 1.07%, and the total American population is 285 million, so 285 million, that would make 3 million people carriers and 1 million people, 1 million deaths from anomalous coronary arteries of the opposite sinus, which is not the case. So these numbers are not that, I guess, cannot trust these numbers that much. So we're trying to look for, so what we need is a big study specifically looking at assessing or trying to quantify the risk of sudden cardiac death in patients specifically who have a right anomalous coronary artery from the left aortic sinus, and we don't have that. But there is a registry out there for anomalous aortic origins of coronary artery. And so basically we just need more data to quantify that risk. So if you review the literature, there's 2 main opinions regarding this issue. The first is that symptoms are not reliable, and the first is often sudden cardiac death. So surgery should be indicated in all patients who have an inter-arterial course or other high-risk anatomical features such as an intramural course. Another opinion is that we shouldn't be using cardiac surgery, which can have high risk and can have negative outcomes like damage to the aortic valves as a treatment for anxiety and prophylaxis in these cases. So in our patients, he did not have any disabling symptoms. He also, we cannot document any myocardial ischemia or any problems with perfusion, so we decided to manage him conservatively. So he was told to stop smoking and avoid extreme exercise, and he's going to be coming back every 6 months for a stress test.
Well, he'll be back in 6 months. Yeah.
And that concludes our presentation.
So what do you think, Dr. Angelini?
It was a very good presentation, very, very good review. Minor points can be improved, but I think the message is strong, that there is a lot of confusion in a subject that is quite interesting to study. Yes, we need more numbers, more cases, but we need especially more precise data. In general, you got the general terms of the discussion as correct, that there is a stenosis causing symptoms, but we don't know when ischemia is real and how to measure ischemia. Measuring mortality as the only indication for intervention is quite dangerous, because basically the anatomist, the pathologist, will see only the bad cases, and it is impossible to establish indication for intervention based on the people that go to autopsy. They all have a bad outcome. So it's too extreme to indicate surgery in everybody just because of a condition that we know occurs in others that didn't die of this. But this is pretty much the reason why we do so much studies now, both clinical, and we came to the conclusion that IVUS is the best way to calculate severity of stenosis in individual cases. And in the pathology, we have here one member of our group that is studying the pathology findings in the forensic center here in Houston, a 5 million people population that every year has something like 3,000 deaths, and we study the incident prevalence of these conditions both in people that die of sudden death and they are young, and people that don't die of sudden death, and see the difference in incidence of these anomalies, because obviously the anomalies are there, but they are not always or even frequently associated with sudden death, especially the right from the left. The left from the right is more of an open dilemma. But in clinical grounds, we need to have data. There's measuring both the severity of the obstruction and the severity of exercise, because exercise does definitely something special to these patients. These are kids typically. The great majority of the deaths associated with the congenital anomalies are during exercise and before age 35. And the probability that this occurs because it is the first time in the life of an individual, especially in competitive sports, that the aorta and pulmonary artery are stretched to the limits. There is the maximum amount of stenosis that at baseline is important in some cases, but especially can be much worse with maximal increase in blood flow and tachycardia, and expansion of the aorta are the main determinant of the variability of stenosis in these patients. So these are fascinating subjects. We are not even close to conclude the discussion. Unfortunately, we need to live on inadequate evidence, but I think we now know better than before what to look for. More cases, yes. More precisely described cases, very much the urgent call for the cardiologist. We need quantification of the stenosis and quantification of the exercise that possibly is related to the sudden death.
So when you're doing IVUS in these patients, are you doing simulated exercise with dobutamine, saline IV boluses? I saw one paper you wrote that described a possible way to evaluate patients with known and to do this hemodynamic challenge under IVUS as a possible way to discern who's going to benefit from surgery or not. Obviously, you would need a lot of cases to discern that, but are you doing that right now?
Yes, we have basically this policy, and everything has been reevaluated. Unfortunately, in a clinical study, is not a large group and is not multi-center, is not prospective. But we are in the process of publishing this initial 75 cases or 70 cases that were collected in our institution over the last 12 years. In those cases, in every one we did IVUS. In 30-40% we did a stress test simulating exercise in the cath lab with dobutamine, atropine, and bolus infusion of saline to increase the stroke output in this patient during the stress test. And the policy now is mildly improved. Still, we're in search of more definitive data, but the policy is to do IVUS in every patient that has significant symptoms, disabling or that put at risk athletes, marathon runners, military people, professional athletes. In sedentary people, the right is extremely rarely associated with sudden death. And if you have a large series of sudden death, you're bound to have some with the right coronary artery from the left. But to establish the cause-effect of the association is quite difficult. So we're still working on the numbers.
So how do you recommend anything further in this young man? I think we've done 2 stress tests on him, submaximal and a maximal. Obviously, he's got a pretty decent dominant right that supplies a good portion, gives this lateral branch, so supplies the infralateral. So it's pretty big area it supplies. Obviously, it looks very pinched and hypoplastic here, angulated takeoff. It has all the makings of a very bad harbinger with very atypical symptoms and negative ischemia.
Yep.
Where do you go from here? I guess that's the question for this young 20-year-old who, obviously is enjoying life and is now a little scared, but, been reassured after 2 stress tests. But I don't know if I've been reassured, So that's why we're here today, I guess.
Yeah, unfortunately, if you look at the case reports of sudden death, that's the most important part of these studies. We need to have detailed information of what happened before death, because these especially trained athletes had similar level of exercise many times in their lives, and they died only one time. So there are additional predisposing factors: dehydration, heat stress, the volume dehydration, at the same time overhydration or excessive amount of Gatorade could be related to this event. The fact is that we need to know both the condition predisposing to the final event and the mechanism of death. Was it in bradycardia or in ventricular fibrillation? Ventricular fibrillation is more in favor of localized ischemia. Bradycardia, which is in my perception the most frequent mechanism of sudden death, is more suggestive low cardiac output, and that could be in the left from the right, especially a reason to think of intervention to prevent ischemia from maximum exercise, and stenosis with maximum exertion is difficult to reproduce in the cath lab. But this is all evolving, and I think it is going to be a slow and progressive progress, but if we have the proper general culture, it will eventually come to fruition and a solution. Evidently, not everybody with these anomalies die. Not everybody has the same level of stenosis, but stenosis is the basic clue, and is a variable, labile measurement. We need to do these studies more frequently and more precisely.
All right. Well, thank you very much, Dr. Angelini. Do you think I need to send him over, or can I just follow him for a little while?
I think you're perfectly correct. You did what is correct to do. Maximal exercise, proved on no ischemia with maximal exercise. You follow the patient clinically, and the patient clinically is doing well, reassured, and basically follow up more than treated. There is no treatment that can increase the symptoms, or they can improve the probability of sudden death. beta blockers, if they work because they decrease the maximum heart rate. Was that the reason for not reaching the maximum heart rate in your patient?
Well, in the first study, he got acutely nauseated, and we had to stop, and so we weren't able to achieve target heart rate, and so that was the information we had on hand at that point.
Yeah. That was on beta blockers with dobutamine.
That was he wasn't on any medications. Young, healthy guy, no medications. Just gave him dobutamine and atropine, and just got acutely nauseated. I think we had a pretty long, extended protocol that we were in the early phases of building, and we left him on dobutamine for, I think, an excessive amount of time, and I think that's what happened. And in the meantime, go ahead.
Ecotreatment is probably more practical and more predictive than dobutamine or dopamine.
Yeah. I think we were trying to assess for maybe some possible cardiomyopathy at the same time, and also for probably RV subendocardial scarring, which we've seen in some other papers as a possible harbinger of these evidence of ischemia in the past. So we didn't find either of those. So
very good. A great presentation. Thank you.
Good job, Esma. Thank you so much, Dr. Angelini.
My pleasure.
We really enjoy these presentations. Hopefully we can continue and get more people involved.
We love them too.
Thank you.
Thank you. Bye-bye. Now you want your slides.